thank you everyone again for joining the GlobalSurg 3 webinar. As I think you probably all know, we were absolutely delighted that the paper was published at the end of last week in the Lancet. What an absolutely fantastic achievement for our collaborative effort on this study. We're delighted to be joined by our panel members who I will ask to introduce themselves briefly in a minute. We've got Anil Bangu joining us from Birmingham University, Stephen Knight from Edinburgh University, Tom Weiser from Edinburgh University, and Professor Ewan Harrison, who has led the GlobalSurg 3 effort from the start. So perhaps if I could just ask our panel members to introduce themselves briefly and say hello to our audience. Anil.
Hi, it's a pleasure to be here and to speak to everyone. I am a consultant colorectal surgeon in Birmingham, the United Kingdom, and I'm a clinician scientist in global surgery as part of the global surgery unit we run across Birmingham and out of Birmingham and Edinburgh.
And Stephen Knight.
Hi everyone, I'm Steve Knight. I'm a clinical research fellow at the University of Edinburgh, looking at global surgery and outcomes for my PhD.
Thank you, Stephen. Tom?
Yes, good afternoon, everyone. My name is Tom Weiser. I'm a general and emergency surgeon. I split my time between the University of Edinburgh and Stanford University, and I'm delighted to have been a part of this incredible study, and looking forward to the discussion this afternoon.
And finally, Professor Ewan Harrison.
Hello, I'm Ewan Harrison, surgeon and data scientist in Edinburgh.
Thank you, panel. So again, thank you very much and congratulations to all our collaborators for this amazing effort to get this study published. I know at times it's felt like a long time since we collected this data now on breast, gastric and colon cancers, but in the midst of a pandemic and everything else that's been going on, I think it was an amazing effort to get the study out. So I'm going to ask Ewan now to present the key findings of the study, which will form the basis of our discussion. Over to you, Ewan.
Can you see my screen okay?
Yes.
Perfect, thank you everybody, and thank you Katie for the kind introduction. So we were hoping to be joined by Dhruv Ghosh, who led the study in India, Rachel Moore from South Africa, and a number of our other colleagues, including Stephen Tabiri in Ghana. And unfortunately, for various reasons, they're unable to join us today. Dhruv has just emailed me to say that he's stuck in theatre, for instance. So it's a great honour to present the results of this study, which has really been performed by literally thousands of individuals across the world, and massive credit needs to go to them. So in 2018, we modelled that 16 million people will be diagnosed with cancer worldwide, and 4 out of 5 of those individuals will need some sort of surgical procedure as part of the diagnostics or management of their cancer. And yet, as many of you know, fewer than 1 in 4 people worldwide have access to high quality surgical care. Cancer is a priority for surgeons, no more so because the incidence of solid cancers is rising globally, but particularly in low and middle income countries. But what do we actually know about the provision of surgical cancer services worldwide? What do we know about differences in the quality of cancer care that surgical teams are able to provide? And what do we know about the outcomes of cancer surgery, and particularly the immediate outcomes, those that happen within the first 30 days of cancer surgery? And the answer to that is very little, due to the difficulties of studying this worldwide. And in particular, we are always thinking towards what actual interventions will make a difference to this. What can we do that will improve outcomes for patients worldwide undergoing cancer surgery? The GlobalSurg Collaborative performed this study over 5,000 collaborators across over 100 countries. This is now the 3rd large collaborative study that's been performed, and it sits within the NIHR Global Health Research Unit on global surgery, an opportunity for hubs worldwide to receive funding directly in order to support research in low and middle income countries. Cancer was prioritised by a wide group of individuals, including those from low and middle income countries, at our annual research prioritisation meetings. And so this was in Kigali in 2018 that this study was conceived of and designed. So without any further ado, that we were delighted, as Katie said, that that the work was published in the Lancet at the end of last week. The study is called Global Variation in Postoperative Mortality and Complications After Cancer Surgery, a multi-centre perspective study in 82 countries. So it looked at individuals undergoing cancer surgery. The denominator is patients who are having surgery. And we looked at those undergoing breast, gastric, and colon surgery. The most important, not the most important, but those that with the solid tumours with the highest incidence and that contribute most to mortality from cancer worldwide, and also that are managed commonly by general surgeons in low and middle income countries as well as high income countries. And we're particularly interested in looking at outcomes in the 30-day period after surgery and looking at differences of those. This is the first study of a number which will be published using these data. It would be great if you wanted to get involved in the further analyses that are ongoing. This is the richest data set which has been gathered with over 120 variables looking at various aspects of cancer surgery. So a great opportunity to look at things in more detail. The study owes a lot to a number of individuals, but particularly those that were involved in running the study, translating the protocol, for instance, so that it was able to be performed across countries. And we spent a lot of time thinking about how it could be performed to the highest quality. So collaborators underwent training, primary data was performed, but also the data that were collected was validated by a second set of individuals collecting data. And we also collected data at the hospital level. We encouraged collaborative analysis, and I'll mention that at the end. So we collected data on over 16,000 patients, and that was in 82 countries across 428 hospitals, 836 teams of individuals, almost 2,500 collaborators collecting data in breast, colorectal, and gastric cancer surgery in the right-hand box there. This first study was particularly orientated towards the stage of presentation of cancer and whether that predicted whether patients were going to have complications or whether patients were going to die after surgery. As many people know, the presentation, that when cancer comes to light in low-income countries, it's often at a more advanced stage. And we saw that very clearly with the data that we collected. So these graphs show the proportion of patients presenting with advanced disease, stage 3 or 4, compared with early stage disease, 0, 1 or 2, across high, upper middle and lower middle income countries. So for instance, almost 60% of breast cancer was stage 3 in low and lower middle income countries. So a clear relationship between the later presentation of cancer and country income group. We also showed a higher incidence of mortality and a higher incidence of complications in low and middle income countries. So for instance, for those undergoing gastric cancer surgery in the middle there, or on the right hand side there, 10% of those patients died by 30 days after surgery in low and lower middle income country groups. However, and this was an important finding that we showed, the rate of complications was similar across countries. So while mortality was higher in low and middle income countries, the rate of major complications and the rate of any complication was very similar. And that is, I think, what we'll focus on discussing after I've shown a couple more slides. Adjusting for all of the differences that we saw in patients, whether that was nutritional, age, sex, whether people had lost weight, the types of surgery that were going on, trying to take into account as many differences in the explanation for why mortality may be higher was performed in a lot of detail, and we still showed differences in mortality across country income groups, but didn't show any differences in complication rates. So those in high income countries compared with those in low and middle income countries had the same risk of complications. So 2 more slides on the results. What predicted whether patients who had a complication went on to die? And that's what these final plots in the paper show. That, for instance, those that are older, those that are more frail, those that have higher surgical risk, all of those things contribute, as would be expected, to patients with complications going on to die. And looking at that in detail, we showed that about 60% of characteristics of patients dying rather than living who had complications was explained by patient factors or disease, but 40% of that difference was not explained by patients or disease. So by the time you take into account a patient being frail, by the time you take into account a patient being older, by the time you take into account the circumstances in which a patient is undergoing surgery, cancer stage stops being very predictive of whether patients are going to die when they have a complication. We went on to look at the post-surgery facilities that were available. Were there dedicated wards? Was there critical care available? Was there CT scanning available? And that was shown to be a very strong predictor of patients being able to be rescued from a complication. And finally, we showed that if better post-operative facilities were available across high, middle, and low-income countries, then these are the number of lives that could be saved per 100 complications. So in this example at the top, in a low or low-middle income country, a patient undergoing colorectal cancer surgery with better post-operative care facilities, 7 out of 100 patients, of 100 patients having a complication, 7 extra lives would be saved. So in conclusion, high levels of mortality after cancer surgery are not fully explained by the later presentation of disease, but being able to rescue patients from surgical complications opens the opportunity for meaningful interventions to actually be able to do something to save lives. And actually, early death after cancer surgery may be able to be prevented by better post-operative care. It's something I think that we all working in surgery feel makes sense. We know that when patients get good care after any type of surgery, then complications can be picked up early, and that spiral of multiple complications occurring and a patient dying as a result can be prevented. The data is all open. If you go to cancer.globalsurgery.org, then the full data set is there to be able to be explored today. You may find things that we haven't found yet. There's ongoing studies which everybody is welcome to become involved in. We have all the quality to look at, the availability of pathology, of imaging, of neoadjuvant and adjuvant chemotherapy. There are audit standards built into the study. There's a nutrition study ongoing, particularly orientated to gastric and colon cancer. Staging is of particular interest, and access to surgery across all cancers. As I said right at the beginning, an immense number of people have been involved in performing this study, and only a few are able to be here presenting the data. And I just particularly want to mention one individual from Egypt, Hosni Keri, a collaborator very close to us all, who tragically lost his life while this study was being performed. So we have dedicated this first publication of GlobalSurg 3 to Hosni Keri from Egypt. Many thanks, and I look forward to questions and a detailed discussion with the panel about some of these findings that we have shown. Thank you.
Thank you, Ewan, for a really nice tour through the highlights of the GlobalSurg 3 data. I wonder if we could just start by revisiting your point about the data collection and the data validation, and the richness of this data set, and what further analysis we might be able to do. I think it's worth maybe sharing with our collaborators that the peer reviewers at the Lancet were really complimentary about the actual quality of the data and the efforts that everyone went to ensure that happened.
Thank you, Katie. There's patient level data and also data at the level of the hospital. So it's a very rich opportunity to really delve deeply into what is going on in cancer surgery around the world. So there's data, almost complete data on 16,000 patients. And really, we have only scratched the surface with this first publication, where we have tried to include information about all cancers. So, for instance, one of the first things which we really need to get published quickly, I think, is an in-depth look into breast, gastric, and colon cancer separately, to understand in more detail exactly what is going on in these almost kind of very different cancers.
So plenty more results and publications to come from this data set. We're going to move to a question from our audience now. Dimitri from Birmingham University has asked, are there any important differences between elective and emergency surgery?
Yes, I was pausing there to see whether you were going to direct that to somebody. Steve Knight may want to come in on this as well. So emergency versus elective surgery is a strong predictor of mortality after cancer surgery, as it has been shown to be in our last study, which looked at abdominal surgery, the GlobalSurg 2 study. And emergency surgery is associated rather with higher mortality, even after accounting for the sorts of things that make patients predict as an emergency. So, for instance, in colorectal cancer, obstruction of the bowel. So there are definite circumstances around the provision of emergency cancer surgery which are associated with greater mortality. And that's certainly something that would warrant being looked at in more detail. I'd be grateful for Steve Knight and maybe also Tom White, well, everybody, for their thoughts on that.
Thanks, Ewan. Certainly what was interesting within the data set was the proportion of emergency cases was around 10 to 15%, which is perhaps not as high as we may expect. And I certainly believe that we need to delineate those emergency surgical patients further with additional analysis in order to try to work out whether there are other influential factors, not only both for 30-day mortality, but major complications following surgery across all income settings.
Can we move on now to talk in more detail about the capacity to rescue? Tom, I know this is a field that you have a lot of experience working in, I wonder if perhaps you might want to just comment in general about capacity to rescue and exactly what we mean by that. And then perhaps we could have a discussion about what are the sort of post-operative infrastructure and processes that could be easily implemented to improve outcomes for all patients.
Thanks so much, Katie. So this is a fascinating part of this study, and something that really struck us as we were reviewing the data. And the concept actually is an old concept that is really traditionally expressed as what's called a failure to rescue. And about 8 or 9 years ago, a group from the University of Michigan in the United States identified this issue of what they called failure to rescue amongst hospitals in the US. And the Michigan group was looking at low mortality and high mortality hospitals. And they classified these hospitals based on mortality rates following a set of very standard procedures for cancer. And what they found was that the difference between low mortality and high mortality hospitals was not a difference in complication rates, but differences in the ability to rescue patients following a complication. And they reanimated this term called failure to rescue. The idea in the US is that hospitals that are quite well resourced and are delivering fairly advanced cancer care should look very similar with respect to infrastructure and with respect to their organizational and clinical care capacities. But in fact, some hospitals were failing to rescue patients while other hospitals did a very good job. Obviously, what we have noted in the work here is that there's a tremendous difference in capabilities, in resources, in infrastructure, human and material resources, in organizations, in the allocation of materials, in the allocation of even space for post-operative patient management. And so rather than terming this a failure to rescue, there are places that are missing vital components around vital components and vital materials, human resources, material resources, space resources that are required to provide really strong management practices in post-operative care. And so we flip the term to be one of capacity to rescue, because there are investments and there are opportunities, not just in low and middle income countries, but in fact around the world, where investments in resources and investments in capabilities will actually translate to improved patient outcomes. And it's not a surprise, it's just this is the first time that this has really been characterized and actually quantified in this way.
And on a global setting as well, rather than just in a single country.
Exactly.
So Anil and Ewan, well, and Steve as well, as surgeons, I'm not a surgeon myself, but could you give us some examples of what the sort of post-operative interventions are that could be added to the capacity of hospitals that and help them improve their capacity to rescue? What sort of things are we talking about? Anil, would you like to comment?
Yeah, thank you. I think the implementation of this data is going to be really important, and it's going to be context specific to everyone around the world. That is, there's not going to be one thing that everyone can take away and do, because everyone does things slightly differently. I actually put it out there that every hospital around the world is different. And so there are some common things, training of junior doctors, training of nursing staff that everyone could deliver and ensure. What I would say specifically about this paper is I would encourage everyone to go and look at the supplemental data. Supplements are becoming more and more important in papers like this as time goes forward. They used to be just a few pages of complex figures, but now it's where we put the detail. So for example, I'm a colorectal surgeon. The supplement of this is thorough. I would ask people to look at page 41 of the supplement to be specific. And there you can begin to see some of the things that all of the sites across this global study were doing. You can see how many places had a tumor board, an MDT, who had post-operative care, who had CT availability. What this means is that you can begin to just benchmark your individual hospital against what everyone else is doing, and it can begin to signpost you to where you can then improve your care and identify almost what you're not doing. And that's how you can take messages from this paper. And as you look at the other tables and begin to, fitting with what Tom says, at the top level, we've identified a problem around this concept of failure to rescue. At a medium level, we've identified that is, in that immediate post-operative phase. Then you need your micro level is up to each individual surgical team and each individual hospital. They then got to take this information away and figure out which bit of it applies to them. So there are like I say, there are some general things, but there'll be some specific things as well. But I don't think we could create at the moment, not at this moment in time. This is probably something for the future. How we create that list of things that everyone needs to more definitively implement in their practice. Let me stop that.
Yeah, so almost to create a basket of surgical care that could be implemented to improve capacity to rescue post-operatively.
True, but I would very much advocate that is done under testing. As clinical teams, we're subjected to a lot of different strategies for improvement. And I think everyone around the table here is involved in some form of trial that is testing interventions. There are many different ways to test interventions, and it doesn't really matter. But I think it's important to test your intervention to make sure that you are, if you're going to ask everyone to do something, it is worthwhile.
Mm-hmm. Yeah, I think actually now is probably a good time to talk about the hospital level survey as well, because I think the data that Anil's referring to there actually came from the hospital level survey, which Stephen's been leading the work on, and where we asked our collaborators to tell us what facilities they had available to us. Steve, do you want to just talk about some of the ongoing analysis with that data that's maybe not yet come out in the Lancet paper?
Thanks, Katie. Initially, I'd like to just build on Anil's excellent summary. And I think one important thing that is contained within the literature, and we've highlighted within our analysis too, is actually that although we've looked at post-operative care, we're probably looking here at indirect markers that represent other structural and process measures that are closely related to outcomes following surgery after cancer. So even though we've said a presence of a CT scan, a perioperative or post-operative care area, and a specialist ward for intensive monitoring and treatment, that is likely to represent not only training, but staffing and other processes that support the recognition and timely management of patients post-operatively with complications. And we've then moved on to a further analysis looking at the hospital level survey, which is looking at around 20 to 30 hospital characteristics, namely whether a hospital has an MDT board, the presence of an oncologist, presence of CT scan, the nature of the hospital, whether it's a referral hospital or a specialist cancer centre. We're trying to delve deeper at the moment, looking at trying to develop a surgical cancer care basket, which can hopefully identify those processes and characteristics which not only predict mortality, but potentially predict this capacity to rescue following a complication.
Thanks, Steve. Are there any more questions from our audience? Just remember, you can type in the chat box if you want to ask either a question about the GlobalSurg 3 dataset or about the collaborative in general. Are there any other points that our panelists want to bring up for discussion? Anil.
So Steve, good summary. I've got a question for you. Mm-hmm. And he doesn't know this is coming, so it's not staged, don't worry. So again, let's move to the implementation of data. And if a lot of this network has been junior doctors around the world, is that a fair comment?
Yep, that's fair, yep.
So what if I'm a junior doctor sitting somewhere around the world, and the junior doctors are the agents of change, we call them. Mm-hmm. What am I going to do with this? What is my next step with this information? What should I do practically?
No, I think it's important in terms of implementation science. Certainly, I think there's more to come out from this data first. Try to identify, are there even more important factors, or can we grade these factors into highest importance to lower importance? So therefore, potentially is the presence of a perioperative care area with a pulse oximeter and persistent monitoring of vital signs with a specialist staff, which potentially is more attainable and achievable shorter term and with lower cost than looking at, say, trying to identify and source and bring in a CT scan to the hospital, which obviously involves a lot of levels of infrastructure and specialism. So I think we have to try and start small, try to identify those processes which are achievable, and then that's a stepping stone to starting to build up, say, a perioperative care pathway where we can try to identify complications early and intervene as quickly as possible.
Tom, have you got anything to add to that from your experience? Yes, you've got your hand up.
Yeah, actually, so Anil, the question is spot on, because at the end of the day, the challenges are pretty enormous, and the idea with the next kind of set of analyses is to start creating what what you might call a roadmap. And there are going to be some things that are going to be way beyond the ability of a junior doctor, or let's be honest, even consultant or senior physicians to implement or to change. So obviously, high cost capital expenses like a CT scanner, that's a really big investment. And then even with a CT scanner, if you're talking about the skill sets of, say, an interventional radiologist or some kind of interventionalist, these are really, really difficult skill sets to develop and refine and then plug in, and also figure out how do you pay for and how do you integrate it into an entire hospital ecosystem. On the flip side, there are things that are absolutely imminently doable that Steve mentioned, things that are probably more based around behaviors and organizational work. It's not to say that they're easy, but those are things that don't really require the capital investment. They do require a massive amount it's very effortful. It does require a lot of effort and investment of time and intellectual energy. And the way that that we've done this kind of work in the past, especially through an organization like Lifebox, which I'm the consulting medical officer for, is really around team building. So building these multidisciplinary teams that go way beyond the junior doctors, but include the nurses, include anesthetists, include administrators, include other perioperative personnel, so that problems can be identified collectively and then tackled collectively. Those kinds of problems that are addressed in that way, while they take a lot of effort, typically don't take a lot of cost investment, but don't be mistaken, they do take a lot of energy, and progress is made in fits and starts, but that's how we make progress, is starting small and working our way bigger. And then, as you say, Anil, studying the problem and knowing whether or not what you're doing is making an impact.
Do you think there's a role for something akin to the WHO surgical safety checklist, but an almost post-operative safety checklist to make sure that patients are being monitored properly and the correct interventions are happening when they're needed?
So, absolutely. In fact, along with the WHO surgical safety checklist, there was around the similar time was what was called the SURPASS checklist, which was a study from out of the Netherlands, looking at a much larger, massive, or more expansive checklist that looked at kind of preoperative, perioperative, postoperative, and even kind of post-discharge, an extended checklist looking at compliance with standards in those domains. And that checklist was very, very profoundly impactful on improving patient outcomes. So there's absolutely a role for checklists. Again, a tool like a checklist is only as good as its implementation and its use and integration into a routine. And the idea behind safety tools like checklists really is around how do you organize teams to ensure that what you think is happening is really happening, and that information is being communicated, particularly across disciplines, across space and time. And the hard thing is, as Steve said, what we're really looking at with these other markers, they are just markers. They're surrogates for what we really want to know, which is how do people behave, and how do teams communicate information about a deteriorating patient, escalate that information, and then allow interventions to be made in a timely way that then rescues patients from complications or ensures that all the things we want to do are done, in a timely way and very efficiently.
There's a big role for communication to the right person at the right time. Yeah, Ewan.
Yeah, just to add to all the excellent comments. I mean, when you get right down to it, what we're talking about is detecting complications and acting on complications to kind of mitigate their effects. And the detection of complications can be relatively simple things like early warning systems, whether a patient has a high pulse rate or low blood pressure. So was it Sam Shem in the House of God famously stated, if you don't take a temperature, you can't find a fever. And that's it, without simple systems for observing how well or unwell a patient is, then a complication can't be detected at an early point. There are complicated ways of detecting complications as well, like CT scans, which are not going to be possible to implement in certain places. And then the intervening on complications could be relatively straightforward as well. It may be an antibiotic, it may be opening up a wound, it may be taking someone back to an operating theatre, or it may be a complicated thing like interventional radiology. So there are kind of lots of facets. But I think what Tom Weiser and Neil and Steve all got at, it's how do you have a robust system, almost an organism in which humans are agents, which consistently does this and accounts for human error and has layers of backup in order for when things don't work the way they should do, that patients don't slip through the net. It's that which I think we're only beginning to get a handle on in medicine in general, but in post-surgical care in particular.
Thank you. Any other questions from the audience or points from our panel members? No, I can't see anyone chatting. If there are any questions, do type them in the chat box. I think if there are no more questions or comments from the panel, we'll think about winding up there. But I think I would like to just finish with a few points about the power of collaborative research and how far we've come from the early days where Anil and Ewan and colleagues came up with the model of using junior doctors and medical students to form mini teams to collect data. And now we're really at the stage where we're carrying out multiple global studies at the same time and really starting to influence policy. In fact, maybe Anil, if you've got any comments to make about the NIHR Global Surgery Unit and policy implementation that's coming out of all this amazing collaborative research effort.
Yeah, and where we are pushing toward is this whole research paper and then clinical practice, and bridging that gap is going to become everything in the future. Open access, dissemination, and pushing it into clinical practice as fast as possible. Two comments about the future direction of research. I think the NIHR in England, on the basis of the recovery trials, which have been the COVID trials, have shown just how important quick, effective randomized trials are. I think you'll see them coming back into fashion in quite a way over the next decade. And actually, I think we can definitely collide that. We've been planning a body of work called the Giraffe trial, which is really early phase, but it's around, how can you actually go and improve post-operative care. And it's everything we've been talking about and putting it together. And so there is no reason that these things can't be done as part of research, firstly, to prove what works, but secondly, to implement it as well. Good randomized trials are a way of pushing this practice into everyday life. And so you are empowering your junior doctors to train each other and to learn how to communicate. And then at the end of the trial, if things have worked, you push them forward further. If things haven't worked, you can pull them back. And actually, I think that is what the immediate future is going to be. I think our responsibility here, and if everyone who's taken part, is to make sure that this stuff is going to happen over the next 12 months and not the next 12 years.
Yeah, timely delivery is essential. Any other final comments, either from our audience or from our panel members? Ewan.
I mean, maybe just one comment to say a big thank you to everyone who has contributed to this study. I think we can't emphasize too much how the only reason that these studies exist and the only reason that the data in the final papers exist is from all the hard work of everybody contributing. And it's only with this massive team effort that this can be done, as you have said. So really just a big thank you to everybody for contributing so enthusiastically to this work.
It is amazing watching the number of collaborators and the number of patients in the database go up as the study rolls on. We all get very excited when we roll round to a new 1,000. Tom or Steve, any final comments?
Just to kind of reiterate Ewan's thoughts and comments about how incredible this has been, that over the various iterations of GlobalSurg, going through 1, 2, and 3, that the number of collaborators and hospitals has dramatically increased, and I think that's detriment kind of to not only to the effort of the head team, but also to the collaborators, to spreading the message far and wide, to getting their colleagues involved in various parts of the world.
Yeah, and I guess my last point would be that, you know, we're only just beginning in many ways. There's still so much to know, as Anil mentioned, not just in what is happening, but how things happen and how we can make things better. So there are tremendous opportunities for junior researchers, other collaborators, other hubs, and in fact, the solutions for problems, as Anil said right from the beginning, is going to come from various people from various countries and settings trying different solutions, evaluating their impact, and then sharing that knowledge. And we will all learn collectively together as we all try collectively to make improvements and make surgical care a little bit safer and a little bit higher quality for everyone. And that doesn't matter where you are. Everyone can make a small contribution that will make a huge impact.
Yeah, well said. That's the great place to wind up. Everybody's contribution collectively together makes a big impact, and that I think really sums up this study nicely, the massive global effort and the big impact that we've had at the end of it all. So thank you everyone for joining the meeting today and for being part of GlobalSurg. We really hope that you'll carry on being part of GlobalSurg and join the COVID-Surg and the GlobalSurg projects and all the other initiatives that we have going on. And hopefully we'll be able to have another celebratory webinar again soon for further successes. So thank you very much, everyone.